today we're going to talk about nursing facility clients that are receiving hospice care and the payment and process change as of date of service May 1st, 2013. So much of this is a review of a previous training we had back in November, but there is a lot of new information as well, so please do stay tuned. So introduction, nursing facility providers should be on the line. Also managed and coordinated care representatives. And then I think we'll just go around the room and introduce everyone that's here. Again, I'm Jennifer Smith. I'm the Oregon Health Plan Trainer.
Cindy Susi, Aging and People with Disabilities. Becky Coltrane, Aging and People with Disabilities Policy Unit.
Judith Van Osdell, DMAP Policy Analyst for Hospice Services. Vivian Van Hatten, DMAP Provider Services Nursing Facility Liaison.
Nathan Singer, Field Support Manager, APD.
Renee Shear, Nursing Facility License.
All right, so everybody that's on the screen is here, and then we have some bonus folks in the room as well. So lots of knowledge sitting around the table ready to help you. All right, let's go ahead and start with our topics for today. So we're going to talk about that payment process change and billing for the hospice clients that are residing in nursing facilities. We'll have an Oregon Health Plan overview and breakdown. That's just so you have an understanding of why you're working with both APD and DMAP. We'll talk about roles and responsibilities of both the hospice provider and the nursing facility. And then communication and coordination of client care, Medicaid and Medicare coverage and eligibility. All right, so payment process change. Here's our purpose for today. Again, May 1st, 2013, date of service. This new payment process for hospice clients residing in a nursing facility will be effective. So the nursing facilities are going to start billing hospice for room and board for the bundled services as of date of service May 1st. And then hospice providers will bill Medicaid for that payment, including fee-for-service and managed and coordinated care clients. And when the hospice receives payment from Medicaid, they're going to pay the nursing facility according to their contract. Okay, so why is this happening? This is a review, but with a minor change. So this is all per federal statute. We are prohibited from paying nursing facilities directly for these services when the client elects hospice care. So we're required here at OHP to pay the hospice provider an additional amount. Per federal statute, that is at least 95% of what the state would pay the nursing facility. And Oregon Medicaid will pay 100%. So hospice providers, again, they're going to receive that payment, including nursing facility bundled services, and then they will pay the facility according to the contract. So how do providers comply? And this is the contract I keep talking about. The hospice provider and the nursing facility will have a written contract on file and available upon request. And it should address how the hospice care, the provision of hospice care and the method by which the hospice will pay the nursing facility. So all of that must be in a contract between the nursing facility and the hospice provider that's providing that care to your clients. So providers are going to work together to coordinate care for the client and make sure that billing is happening appropriately and that payments are timely and appropriate. So just a couple of things about the hospice and the nursing facility. First of all, the hospice is serving as the overarching manager of care. They're maintaining overall professional management of the medical plan of care. And then the nursing facility is continuing to provide nursing facility services in coordination with the hospice services. Okay, so just a quick Oregon Health Plan overview. The one-pager, pretty simple. So Oregon Health Plan is Oregon's Medicaid program. I think we're all pretty familiar with that. It is administered by the Oregon Health Authority, and within the Oregon Health Authority, the Division of Medical Assistance Program. So you heard me say earlier DMAP. That's who we are. And basically what DMAP does is they maintain the hospice policies and rules, among other Oregon Health Plan rules. We handle the provider enrollment into our Medicaid Management Information System, and we handle billing and payment to all OHP providers. So we do have some policies that are maintained by the Department of Human Services. So that would explain why we have Aging and People with Disabilities, or APD, and DMAP in the room. So APD does all the nursing facility policies, and they maintain the rules for billing and payment to nursing facilities. So we have our first question coming in. With current hospice clients, do we change the billing payer?
So just to clarify, are you asking if a client in April is on hospice and then goes into May? Is that what you're asking about? Is that the change for billing payer? You can reply back there, or you can raise your hand and let us know. Because this is effective May 1st. So if someone is on hospice effective May 1st, they may have previously been paying, the nurse facility would have been receiving payment from APD for that individual, and then hospice would be getting paid by DMAP for those hospice services. That client now in May, and I see you responded to let me make sure.
Okay, so just to follow up on that question, we got they are currently Medicaid with hospice paying all but room and board.
So yeah, so what will occur in May is that those clients who will now be billing, the hospice providers will now be billing for the room and board, and the nursing facility will not be billing for Medicaid for that client. So that's the key difference there. So you all are still providing the services, but technically, yeah, you all will bill hospice per your contracts, and the nurse facilities will bill hospice per your contracts, and hospice will bill DMAP for those services. I don't know if that really addressed it. Sorry. I think as we go through the presentation, that will come out a bit more.
All right, so that's Oregon Health Plan. And now let's talk a little bit about hospice services. So hospice care is intended to meet physical, emotional, and spiritual needs of patients and their families when they're facing life-ending illness. The goal is to provide comfort to the patient by assisting with pain and symptom management, and to enhance the quality of life for both the patient and the family. Hospice care is available to individuals who have been certified by a physician to be terminally ill with a life expectancy of 6 months or less. And OHP covers hospice services for eligible clients residing in a nursing facility, and that includes the nursing facility bundled services payment. So hospice care in nursing facilities, this is federal and state regulations. So the long-term care facility is considered to be the resident's home. Residents are entitled to hospice services. And hospice offers a program of care as defined in the Medicare/Medicaid hospice benefit. So the care scope for hospice, first of all, it includes all of the following, and it may be delivered in collaboration with the nursing facility. So it includes skilled nursing, physician services, medical social services, personal care, spiritual care, volunteer support, and bereavement support. And then we'll talk a little bit about what each provider is responsible for. First, I'm going to go ahead and check out these other questions that we're getting. Oh, not all. Okay, one second. There you go. Sorry about that. Okay, so our next question that's coming in, sorry about that, we had some trouble seeing the questions in the room. It's already a stretch for facilities to receive Medicaid payments after the month has passed. And now, most hospices are saying that it may take another 30 days to get the payment to the facilities, which puts us to possibly waiting 60 days after the date of service to receive payment. I still think this process discourages facilities from having people on hospice.
So just to address that comment a little bit, within this process, the relationship around getting the payment from the hospice providers for the nursing facilities is really a contractual business relationship between hospice and nursing facilities. Our goal is, and we are going to continue to monitor the utilization of hospice through this process. As was mentioned, this is to get into compliance with federal statutes, so this wasn't something the state looked to bring on, but it's really to get in compliance with those federal statutes. Our goal is that, if there are concerns about the payment portion, that should be a conversation you have in your contractual relationship. We have rule language in the hospice rules that discuss, time frames for payment, but really they have the flexibility to discuss those with you in a contractual relationship. So we hope that you all are having those conversations, and that's part of our communication, ongoing communication around this process, hoping that you all have those in your contracts. But we will continue to monitor it because we do want hospice to be available service. But we also understand that is the right of the facility, and you all as business providers decide the services you provide and ensure those business relationships exist.
Okay, next question. We start billing hospice for April or May? So for dates of service beginning May 1st of 2013. So depending on your billing process, that could be June 1st after May is already passed if you're billing monthly. Okay, so what do hospice providers need to do? Hospice providers will initiate or continue hospice services to clients. This should be a seamless process for clients, although clients and their families should be kept informed about what's going on with their care. Hospice providers will implement coordination of care and educate nursing facility staff on the hospice role as the manager of care. They'll coordinate care with the nursing facility providers. And then they will bill Medicaid for both hospice services and nursing facility services. And then once they're paid, they will pay the nursing facility the bundled services rate. Nursing facilities will also continue to serve OHP clients as required by APD rules. Again, just restating, this should be a seamless process for clients, although you are keeping them and their families informed. Continue to collect patient liability and report that amount and any changes to that amount to the hospice so that they can bill appropriately. Work with the hospice providers to coordinate medical care and billing, and then bill the hospice provider for room and board bundled services. Let me check for more questions. Oh, we don't have any new ones after. Okay. So care coordination. These are nursing facility responsibilities. So the social worker and the billing staff should know about the process changes. You'll want to confirm Medicaid eligibility and work with the hospice provider on that, verifying that that eligibility is either in place and what that might mean as far as continuing to monitor client financial status and liability changes. You would notify the caseworker for eligibility changes as needed, and then always identify if the client is in coordinated or managed care. You'll work with the hospice to implement and carry out the patient medical plan of care. And again, you'll continue to collect patient liability and inform hospice, and then you'll build hospice. Hospice responsibilities, again, that top one is pretty much the same as on the previous slide. So it's basically keeping everyone informed about process changes. So the nursing facility, excuse me, the social worker and the billing staff all know about any process changes. Hospice is to confirm Medicaid eligibility with the nursing facility. So they're looking for the Medicaid benefit or qualified Medicare beneficiary. They're obtaining patient liability from the facility. And they're identifying if the client is enrolled in coordinated or managed care. The hospice also has to complete and fax the DMAP 525 notification form. That basically notifies DMAP and APD that a client that's residing in a nursing facility has elected hospice care. So that's how we know here at the state that we need to start paying the hospice provider for the nursing facility bundled services. So that's when this process would start, as soon as we're notified. And then also the hospice submits the bill to Medicaid, and upon payment pays the nursing facility. Okay, so responsibilities of both parties here. You do want to assure that a current written signed contract is on file between the nursing facility and the hospice. You'll work together to verify, implement, and carry out the patient's medical plan of care. You'll collaborate to anticipate and confirm Medicaid eligibility and managed or coordinated care enrollment. And then coordinate payment arrangements for the hospice to pay the nursing facility. And then just an added note at the bottom, the hospice will not be responsible for any of the services that are included in the all-inclusive bundled rate. All right, let me check questions again. Next question. Whose responsibility is it to notify the facility in changes of patient liability? Is it hospice or the financial caseworker? So the hospice is going to be notified of that information by the nursing facility. So the hospice is not going to know it except when that's provided by you, either on a bill or from keeping that communication open between the facility and the hospice. So financial caseworker.
So the eligibility worker should still be letting you know any changes and getting you the paperwork when there is a change in the liability amount. However, the relationship isn't there for them to coordinate that and provide that communication to the hospice provider. So as it's still a business relationship for you all in creating this contract for collecting these funds, that information will come from the caseworker or eligibility worker providing that updated liability information to you all, and then it's the expectation that you all will then let the hospice provider know. The system will still be updated with that information, so it will be available on MMIS. So they should be able to see information, or you'll be able to see information as well related to the liability.
Okay, next question. Can a client receiving hospice care remain on a coordinated care organization or managed care organization? Yes, they can. The nursing facility services are still billed directly to Medicaid, but the hospice providers are aware of that. All right, so communication and coordination. So client eligibility. Nursing facilities are still going to anticipate client eligibility for Medicaid coverage and notify APD area agencies on aging, the eligibility worker. You're still preparing for the changes in client coverage and notifying nursing facility and hospice billing staff, social workers, and other staff. So that's part of the previous slide as far as responsibilities of both providers. You're always going to want to make sure that everyone involved is informed about any process changes. Also verify client Medicaid eligibility. So you're going to do this upon service initiation, before submitting a claim for service, and of course keeping all parties informed. Okay, so this is how the hospice election works. A physician requests hospice services. If the nursing facility receives the request, then the facility is to inform hospice. And then notify nursing facility and hospice billing staff, social workers, and other staff. So once the client elects hospice care, the hospice election form is signed. And then you initiate or confirm. So if you already have a contract, you can just confirm that that contract is on file. So you're initiating or confirming a signed nursing facility hospice contract. And then implement coordination of care. Again, the hospice is the overarching manager of care. And then the nursing facility and the hospice are communicating frequently and sharing care information. Okay, just a little bit more about reporting. So the hospice provider submits the nursing facility hospice notification. So that was that 525 form that we talked about. And that informs APD of the client's hospice election in a nursing facility. And then our system here at Oregon Health Plan is updated. That's the Medicaid Management Information System, or MMIS. If any changes occur, then the hospice provider needs to resubmit that notification. So some of those changes might be if, excuse me, a hospice or a nursing facility discharge, a change in the hospice or nursing facility provider, or a date of death. And then the financial piece, both providers, again, are verifying client eligibility. The nursing facility is responsible for collecting the patient liability and then reporting that liability to the hospice and any changes in liability. The nursing facility bills hospice, and then the hospice provider bills both for hospice and nursing facility services, and they pay the nursing facility according to the contract. And then these are just the revenue codes and the reimbursement. So hospice will start billing those. And then I'm sure all of you know the rates are changing as of July 1st of 2013. And they'll be kept informed of this as well. We have a rate chart for hospice providers. So they're going to have this information as well. All right, let me check on these questions again. Okay, so client coverage. And this just breaks down, again, what coverage a client has and who's going to be billed. So we talked about client eligibility already, so that's just a repeat of that. So continue to anticipate Medicaid coverage for your clients. And then, of course, inform the hospice provider of any changes. And then coverage information. So for nursing facilities, that's over here on the left, and then hospice services are on the right. So you're pretty familiar with this, I'm sure. Clients with Medicare, the nursing facility services are not covered by Medicare, so Medicaid is still primary, and we reimburse per Medicaid rules. And then clients with no other coverage, obviously our Medicaid is primary. And then long-term care, for that coverage, the long-term care is primary, and it is considered payment in full. So hospice services are a little bit different. So if they have a primary payer like Medicare or third-party coverage, those are primary payers. And then Medicaid is secondary and may reimburse any coinsurance and deductibles. And then clients with no other coverage, they would bill Medicaid as primary. And that's for the hospice services only. So a little bit more about long-term care coverage. If the client has long-term care coverage, then you revert back to the current process. So as a nursing facility, what you would do is you would bill the long-term care carrier for the bundled services. You would continue to anticipate Medicaid coverage. Again, I know I've mentioned that a few times. And then always inform the hospice if the coverage is exhausted and when a current OHP financial plan of care is in place. So that's how you know when the new process is going to start, as soon as that coverage is exhausted and we have an OHP plan of care. So the hospice, when there's long-term care coverage, they're going to just bill the appropriate party for hospice services. They're not going to bill the bundled services. And then they'll use the new process as soon as that coverage exhausts. All right. We have a few resources for you. I'm going to check that questions area again. All right. If a resident in a skilled nursing facility was Medicaid and then went hospice on, say, the 3rd day of the month, patient liability is $600. The first 2 days of liability will apply to Medicaid, and the remaining liability would be applied to the hospice days. Is there a special way to bill to inform the hospice that the 1st and 2nd days of the month the money was applied and satisfied by Medicaid?
So the MMIS system will actually take out the liability. It will notice all the days for billing. So when it goes through there and it's pulling out, it will notice that the liability will have already been pulled out in the 1st and 2nd day, depending on, of course, the rate and how much liability there. So there may be a shorter or smaller amount of liability available for them. So the hospice can bill, and they're going to get paid the correct amount. Just like when you all bill, you can bill for whatever dollars you want, but the system will only pay whatever the rate is for the number of units you bill minus the liability that's in the MMIS system. So the system itself will actually keep them from spiking too much. The reason for you all to communicate on liability and for that part is so that way they know how much to pay you. So they're going to be getting a payment, and while they should be able to see what that payment amount is, we want to make sure from a business relationship, you all are communicating how many dollars they should be then transferring over to you. Because it is a contractual relationship, you all set those terms available, and we're really trying to keep out of those business relationships. Our goal is simply so the hospice knows this is the liability amount, and you can let them know we already collected this portion, that's the reason you received less. So there isn't any special forms or reports that go out to hospice to let them know the differences there. That is one of those areas that hopefully you can have a discussion with them when someone does go on mid-month because their liability may have already been pulled out. And you will have to continue to have those conversations with them.
And the hospice provider is going to receive a remittance advice since they are billing for both the hospice and the nursing facility rates. They're going to receive that, and it's going to show line by line what was paid for that specific line. So they're going to have that nursing facility rate, and it's going to say this is how much paid on this line, and they're going to know to reimburse that to you from there. All right, so just a couple of resources. I thought today might go a little quicker than last time just because a lot of this is review. So our resources are, we do refer back to the sections of the Social Security Act that require us to follow this rule. And then also Oregon administrative rules for both the nursing facilities and hospice. And we've actually updated the hospice page to include that notification form that the hospice providers are going to be using. And they also have the current rates listed for nursing facility services. And then if you need further assistance, of course, we have our two groups here, DMAP Provider Services and DMAP Provider Training. And I'm going to go ahead and look back and see if we have any more questions. Okay, next question. I wanted to make sure I understand. If a resident is enrolled in DCO or MCO, hospice provider will bill straight Medicaid not CCO. That's correct. For the clients that are residing in a nursing facility, not for their hospice clients outside of nursing facilities. Incoming question. The hospice provider must reimburse the nursing facility according to their contract, and after the hospice receives payment from the division for that nursing facility for that client. Yes.
I was just quoting out of the rule, and I think related to our previous comment or question around payment.
Okay. Very good. Next question. Beginning May 1st, for cost reporting purposes, do the days that the nursing facility is reimbursed by hospice for, do the days count as a hospice day or a Medicaid day?
On the cost reports that will be submitted for next year, there will be new line items for these revenue codes, and they will now say NIF, hospice, Medicaid, so that way we can keep track of how many days are actually hospice related, even though they're the same rate. So that way when we go to do our budget for the future, we'll have an idea of how many residences are actually. So that will be a new line item on page, I believe it's 13, which is the census report, as well as page 5, where you input the financials.
All right, a couple of questions around the presentation and the meeting itself. So I did send out the presentation to everyone who registered. That was this morning around 7:45. So if you registered after 7:45, you probably don't have it. If you want to go ahead and enter your email address into the questions area, I'll make sure if you don't have it that I'll send it out after the meeting today. Also, we are recording the meeting, so that will be available on our YouTube channel shortly, within the week, I would say. So we'll send out a link to that and let you know when that's up. Next question, do the same rules for Medicaid complex reimbursement apply to hospice clients? Would we then bill hospice the complex medical add-on rate rather than basic? Yes. So that's why we had that slide with all of the different codes that they might use to make that clear. Next question, do we bill the same rate on a UBO4 claim as we do now, but just change to hospice? Okay, so basically that's going to be coordination of care between the nursing facility and the hospice. So you're not necessarily going to be billing the hospice on a UBO4. It really just depends on your contract and what you work out as far as your business processes are. Just remember that if you have a client that is on hospice in the facility, that hospice will be billing Medicaid and you won't. Okay, next question. Do we include these Medicaid census days in our bed tax totals as Medicaid or questions?
Yes, they will be Medicaid, and right now for provider tax, it's all bed days, whether it's Medicaid or not. So we will continue to count them the same. But like I said before, on the cost report that will be coming out for this next fiscal year, it will be included as a separate line item, and it will be included still for provider tax.
Hospices currently provide some care supplies that are included in the bundled rate. Will that end?
No. So, and this is part of the coordination around it, and Judith can jump in and provide some more of the hospice details on it. The key distinction there is hospice provides those for the diagnosis or the area that the hospice is treating, the terminal illness. So the expectation is that the nurse facility still continues to provide those areas and supplies that are part of the bundled rate, but if there is an excess or additional supplies necessary for the individual because of that terminal illness, and it's tied to that terminal illness, that still is the responsibility of hospice that should be provided. We just wanted to make sure it was clear, and part of the rule, it was clear that the payments and the expectations around bundled rates and those services still remain with the provider, the nursing facility provider.
And I'll just add to that, this is Judith. The kinds of calls that I've received in the past related to this are around incontinence supplies. So if you just take that as an example, the nursing facility is responsible when a client is using incontinence supplies before they're on hospice, for example. Say they already receiving and using incontinence supplies. So then the client becomes terminally ill, they elect hospice, now they're on hospice. So you do not shift that cost to hospice. That cost remains that of the nursing facility. However, if because of the terminal illness, the client needs additional incontinence supplies, then the hospice indeed would cover that additional amount. I hope that helps.
Okay, and I think we covered this, but I'm going to go ahead and ask anyway. Will the resident pay the nursing facility for their liability, or will hospice collect that? So that's still being collected by the nursing facility, and you would make sure that you bill hospice appropriately. And the MMIS, when hospice bills us at Oregon Health Plan, will automatically deduct that patient liability. Okay, and a comment here, it is clear in the rule that hospices are not expected to pay nursing facilities until the hospice has been paid by DMAP. And then there was a note to that as well. Let me get down to the other one. Or not. Might be way down there. Okay, maybe later. Okay, next question, comment. The Oregon administrative rule kind of locks the facility into after payment is received by the hospice. So this billing is out of the facility's control and dependent on timely filing by the hospice. Yes, so the hospice provider does need to be paid by DMAP, and that also ensures that the hospice provider is receiving that payment before paying the nursing facility as well. Okay, another comment. I have had very positive experiences in creating contracts with multiple hospices. All the hospices my company works with have stated a commitment to making sure we are paid timely. All right, thank you for that. Next one, the hospice organizations in our area have told the facility that they will not enter into contractual agreements until everything is final as far as the regulations are concerned. Is there any time frame set by the state for contract completion?
So the rules, and I'll let Judith talk about the hospice rule, if you don't mind touching on where that is in the process, and then we'll talk about the APD nurse facility rule. But just to touch on the contract completion portion of it, the contracts are really the relationship between the hospice and the nursing facilities, and again, our goal is to try not to get into the relationship of trying to define or get in between those business relationships with how you work with providers and bringing the services selected by the nursing facility. Our goal is to really define the scope of services and to ensure compliance with federal regulations in each of our rules.
In terms of the hospice rules for the current rate, that all will come in place May 1, and hospices are familiar with it. I'm not sure that I understand exactly what the question is saying, but maybe they just wanted to wait to see when it gets in place that it is indeed what we've all been talking about. So as of Wednesday, May 1, the rules will have the same information in as was trained. That will be updated from the May earlier training and the earlier rules.
And then on the APD side, our nurse facility rules, so 411, 070, 0140. The temporary rule will be filed tomorrow, that May 1st. That's tomorrow? 2 days away. Wednesday. I have to get my days figured out. It's a Monday. So it will be filed and will be effective for May 1st. It'll be filed before that. It's a temporary rule, so that means we will have to have a formal rule process before the end of October 28th. So you'll continue to hear from it, but that rule will be filed, and so that should be out there if providers have questions about what the rules specifically state.
Okay, next question. Is this just for nursing facilities, or is it for assisted living also?
It's just for nursing facilities. So the regulations that cited earlier, the Social Security Act, it was only for individuals receiving hospice in a nursing facility. So other licensed settings, assisted living facilities, residential care facilities, adult foster homes, in-home situations, those are outside the scope of these rule changes or this process.
All right, next question. Will the SNF be able to check MMIS screens for payments for residents who have elected hospice payment or hospice benefits?
So you'll still have access to your MMIS screens. You won't be able to see the payments to the hospice provider. So, same way you can't see payments for other providers, you can only look up your payments related to your provider entity and your rights around your billing offices, so corporate and individual offices with whatever login you're using at that time. You won't be able to see if the hospice has been paid. They would get that remittance to them, but it wouldn't be an open shared information. You would still be able to see client information associated with it if you were to look them up on the provider screen, though, because the plan of care will remain open, so it will be an open plan of care still for your nursing.
Okay, so the next question is almost the same. Will the hospice information reflect and show on MMIS? Yes, but only on the hospice provider's login. So that's not going to reflect for you when you log into the provider web portal.
We do have some additional screens or sections on MMIS that is capturing the information that they're in hospice, and that was around that 525 form when it gets submitted, that it gets updated in MMIS and has some of that information.
Okay. So next question, what will the rates be at July 1st?
Due to legislation, we are not sure yet. We have some draft rates set, but until we make it through session, we won't have final rates set.
All right, next question. It has been my experience that the billing office is rarely notified when a Medicaid patient changes to hospice. What efforts are being made to close this hole through DHS?
So again, part of that comes back to that business process with the hospice organization. And I know, communication's a difficult thing. We know that from our local office's perspective as well. We don't always know when an individual is chosen to elect hospice as well. But that coordination of care really comes down to when a hospice organization's in there, and that's something you can look at in your contract. What are the levels for notification ensuring that you know this individual is on hospice? That 525 form should be submitted, and of course, that goes in. We'll have edits in the system, so in theory, your billings would be denied if you tried to bill if they're on hospice. So our expectations are that hospice is notifying you prior to that when an individual is electing to go on hospice. But again, we leave that up to primarily to your business processes. They're limited enforcement that we can do around that.
Okay, next question. I'm confused about long-term care coverage. Do you mean insurance? Residents receive that payment on their own and then pay us. So the thing about long-term care coverage is that you would follow the current process. Instead of the hospice billing for those services, you're just going to follow the current process that you're following because you're already receiving that from the long-term care or from the resident that's receiving that payment.
Yeah, so we call it long-term care coverage. You may hear the term long-term care insurance, so that is what we're referring to. And again, since Medicaid isn't the payer at that period of time, this process doesn't apply to that individual.
Next question, will the patient liability affect what is paid to the nursing facility by the hospice? So the nursing facility should still receive 100% of the payment. So just as if you were billing Medicaid and the patient liability is automatically taken out of that payment, that's exactly what's going to happen with the hospice provider. They're going to bill those services and that patient liability will automatically be deducted, and then they'll pay you 100% of that payment.
And again, some of this you can define in your business relationship. So again, coming down to a contract, you all can define what you get paid. What we can do in rule is state that we will pay the hospice provider 100% of the rate, the daily rate that individual would have received through Medicaid. So if an individual, yeah, so if they were receiving basic, complex, pediatric, or a special contract rate, they would receive that rate calculated minus the liability. So the hospice won't have that liability. The nursing facility, since you all will be collecting, will have that liability. And so we expect that you all could set up your business processes, but that the shift in payment should carry over the rest of that minus the liability portion.
Okay, next question. Will the hospice provider start receiving a copy of the 458A for any given resident that falls under their care?
No. So that's the form that lets them know the liability for the individual and their financial information. That will not be going to the hospice. That still goes to the nursing facility. So that falls under our nursing facility rules and what we supply to the nursing facility concerning the eligibility for the individual and their financial requirements. So that's the relationship that we have with the nursing facility. So they won't get a copy of that form. That's, again, part of the reason for this and that coordination is really, again, that business process. We'll be notifying the nursing facility of this. That information will be available on MMIS, but not at the level of that's shown on the 458A.
And then is the nursing facility responsible for the adjustments that might occur should the plan of care in MMIS not match the 458A?
So I'm going through all the different scenarios related to that. So technically, again here, this is hospice billing for these services. So hospice is responsible for ensuring they have the funds in order to pay this. Part of that's the contractual relationship between you and the hospice organization. So if, for example, the liability was supposed to be $100 and the worker had not updated MMIS panel at the time that they billed and still had it at $80, then you all would have collected the $80, the nursing facility, or you would have collected $100, the hospice would have received the full payment minus $80. There's a $20 difference there. Once that information is notified, we will be doing those corrections, and that will affect the hospice's billing. The hospice will see the remittance and adjustments related to those, because again, nursing facility isn't billing directly. So again, that's the importance of having the contractual relationship, because they may be coming back to you to say, you know, we either received too much from the state or too little from the state, and having to come to some sort of agreement around your payment, settling those. Again, that's a business relationship, so it's outside the nursing facility for those periods of time. Once an individual elects hospice in a nursing facility, all billing and reimbursement becomes the responsibility of the hospice provider for Medicaid.
So next question, what will be different in tomorrow's webinar with hospice providers and nursing facility providers? Anything new from today? So tomorrow a lot of the information is the same. Our goal for tomorrow is to have both nursing facilities and hospice providers on the line asking questions at the same time. We think it'll be better for coordination of care and getting those contracts started if the other parties know what everyone is thinking and what everyone's asking, and the things that each provider is facing. So that's kind of our goal for tomorrow, but a lot of the information is the same. All right, and I do see lots of email addresses to send out the presentation. I'll do that. Okay, next question. We have one rate when the client is on 5-day respite. When they leave respite and continue on Medicaid, do the billing rates change as what we get on contract versus what Medicaid paid?
This is Judith. The respite situation with hospice has nothing to do with what we're discussing today. This is a completely separate issue. With respite, and specifically for hospice, that inpatient respite care revenue code 656 is the hospice code. That's when the hospice believes the client is residing at home, receiving hospice. The hospice believes the family needs some respite. They can occasionally use this code for no more than 5 days at a time, so then they would contract with a nursing facility to provide that respite for the family. However, the client is not a resident of the nursing facility. This is a very temporary 5-day limit, occasional respite care for the family. So it's not at all related to the process that we're speaking to today in terms of a nursing facility resident selecting hospice care. So I know it is confusing, but it's two separate issues, and that code is the inpatient hospice respite care revenue code 655, and that is, again, where the hospice makes a decision for clients. Client's family needs some respite, and so the hospice makes a contract with the nursing facility to provide that respite. Nothing is billed for nursing facility services. Thank you.
Okay, next question. How would we handle a Medicaid pending client?
So this is always, and you all are aware, this a difficult situation from a billing standpoint. You would continue to treat the billing as you would for any Medicaid pending individuals. They have applied for services. They should have made you aware that they have applied for services. That's part of the reason it was talked about in the presentation, anticipating eligibility. They should have let you know that they've applied, and the case manager and local APD or AAA office should be keeping you up on the eligibility process, whether or not they are eligible or whether or not the state, for financial or service eligibility reasons, the individual is not Medicaid eligible. This process, again, is for Medicaid. We're talking about the Medicaid payment portion for these individuals. So if they're not Medicaid eligible, then they will be responsible for the private portion. That goes back to how you currently do business today for payment related to those individuals in your facilities that are not Medicaid eligible. At the point they are Medicaid eligible, and if they were at hospice the entire time from the period, if we go back to the beginning of the period that they applied for Medicaid, those payments would be done through hospice, so this process would apply. So, example, a Medicaid individual applies for services and it goes back to 4/1, or sorry, to line it up, let's say 5/1, so that way we don't confuse people on dates. 5/1 for Medicaid eligibility. It's June by the time Medicaid eligibility is done. They set up the plan of care for 5/1. That individual, if they were in hospice at that period of time on 5/1 and in the nursing facility and Medicaid eligibility was effective for 5/1, hospice should be billing for that. The edit would be in the system, so you would not bill, and hospice should be reimbursing you for that period of time. So that's the communication. Hospice should be then billing for that individual back to 5/1 with the appropriate revenue code.
All right, next question. If we're attending today's webinar, do we need to attend tomorrow? So you don't have to, but again, that's really just so that both parties can be on the line asking questions. So it's really just for your information. So if you'd like to, that's why we're having it. Next comment, the rules are final. Hospices should be amending existing contracts with nursing facilities for the new process. The Oregon Hospice Association is happy to assist nursing facilities with coordination. Awesome. Thank you. All right. Next question. On what billing format do we bill the hospice provider? Do we use a UBO4? Again, that's going to be coordination, whatever you have set up in your contract. So it could be, I don't know, depends on what you work out, I guess. Will the hospice services for our current Medicaid residents show as a separate benefit plan in the eligibility section on MMIS?
No. So the benefit plan will still show nursing facility benefit. That's the benefit that they will have listed for them, will be authorized. Again, we're not authorizing the use of hospice services. That's a service that they're eligible for under the Oregon Health Plan and or Medicare services. So what you will see on the benefit will still be the nursing facility. You will still see a plan of care there. What there is a new panel on the recipient information screen, and that will actually track and state that they have elected hospice and the time frame for those. So when someone elects hospice, if they change hospice providers and the rest, that will all be located as part of the service.
Next question. It's been an administrative nightmare with getting liability changes correct with us being the primary payer. It's going to get worse with a third party involved.
So again, we know this is part of the process related to this. That's part of the reason, we keep pushing, saying we want you all to be coordinating, and that's part of the reason we've tried to be more proactive with getting communication out there, having these webinars. And again, tomorrow, that's an opportunity for both sides of both parties, hospice and nurse facilities, to really hear around the importance of coordinating with these services. Our local offices, it depends on the information we receive for updating liability. We are continuing to monitor and work with our local offices to make sure they have the information they need around rules and services they should be supplying. So we continue to work to support them and make sure that we're supporting our providers out there that are providing services to our clients. Again, liability can change for various reasons, and we have to make sure we comply with Oregon administrative rules when applying to those liabilities. So that's an area that we're continuing to monitor and work with. And as part of this process, we'll continue to work with and hope that we can continue to receive feedback from our providers around the process in areas where there are continued concerns from our local offices.
Okay. Next is a comment. It is important to be clear that hospices will bill DMAP based on the information the nursing facility provides the hospice. So good comment. Lots of stuff about the presentation. What is the presentation for tomorrow? Can you please send information if available? So the link to register for tomorrow should have come out in an administrative alert. And the presentation, again, it's similar to what we've gone over today, but we've got both parties in the room. So I think it's going to open up some communication between the two groups. So I think it's important that you come if you think that would be beneficial to you. And then the presentation will go out to all those that are registered first thing tomorrow morning. Next question. So we don't need to do anything on MMIS for those Medicaid residents who hospice will now be billing for.
Correct.
Aside from making sure that eligibility is in place and working with the hospice on that. So yeah.
Perfect.
All right. MMIS has problems with the liability that a case manager inputs. Who will be responsible to call the case manager to ask them to correct the liability? Will that be the hospice or the nursing facility?
That relationship around the liability still remains between the hospice and, the nursing facility and the local APD AAA office. So again, the client's residing in the nursing facility, it's the responsibility of the nursing facility to collect that liability. So that relationship still is between you and the local office to ensure that they're representing the correct liability for that client. So if you are the rep payee or you're aware of additional costs that the individual should be, really coordinating between you and the local office and the client to ensure that we have that correct information updated in MMIS. Again, that's part of the reason the comment earlier that the hospice organizations are truly going to be billing based on the information the nursing facility provides to them. They do have some limited information they can see on MMIS, but all the liability information is going to go to the nursing facility.
All right, the next question we have is how to register for the webinar tomorrow. And I'm going to go ahead and send that in the questions box to everyone. So I just sent that link that you would go to register for tomorrow. Next question. All right, next question is, we have several residents whose client liabilities in MMIS are consistently off by a couple of dollars each month. Are the hospice providers being instructed to turn over 100% of the reimbursement from Medicaid to the nursing facility, even if the reimbursement is incorrect due to an error in the client liability? Are they being encouraged to pay the nursing facility only what they are due? Or is it up to the nursing facility to identify the process in their contract with the hospice providers? So it is going to depend on your contract, and the hospice providers are going to pay you according to what you bill, because you're going to be billing them at this point.
So what we've said in administrative rule on both sides is that Oregon will reimburse up to the 100% of the daily rate. So that's our reimbursement. So again, our administrative rules and what we're allowed to do under rule is really to state this is what we will reimburse for services. The contractual relationship around what are paid to each other for those services really comes back down to that business relationship.
Okay, so next question. I love your optimism, but for those facilities on a very tight budget and hospice is slow with payment, do we have anybody at DMAP to help us with this? Or is our recourse to just not continue to do business with hospices that are slow in getting payment to us?
And again, it's going to fall down on those business decisions. Part of the reasons, we've encouraged communication and there's coordination throughout it. And we would like to point out that, you can't stop providing hospice services without going through the appropriate means and direction of notification, et cetera. And there's other people in the room that can discuss that further if there are questions around that process. But ensuring that you have the contractual relationship with the businesses to provide those services and reimbursement for those services in a timely manner really comes down to that business decision. What we have in rule is just simply the language that has been quoted previously in rule around they need to make payment once they've received payment from the department, and that we reimburse at 100% of the daily rate. There isn't a lot more past that is available. If there are billing issues, there is DMAP, as you saw, it's one of the resources, DMAP Provider Services. They're aware of this process that can help hospice with billing issues. as well as nursing facilities if you are getting an error and you have confusion over if this person was supposed to be in hospice and that edit should be taking effect.
All right, so we have a follow-up on a previous question, so I'm going to re-ask the previous question. MMIS has problems with the liability that case manager inputs changing. Who will be responsible to call the case manager to ask them to correct the liability? The hospice or the nursing facility? I would guess the hospice. So let me read the follow-up to that. What I mean is the 458 have an amount, and then MMIS has a wrong amount all the time. We have to call the case manager and have them fix it. So really quick, when I read that question, I stated that it was assumed that it would be the hospice. That was actually part of the question because Nathan did say that that's still the nursing facility's responsibility. So please know that that is the nursing facility's responsibility, not the hospice.
So to follow up on the 458 part of the question, the follow-up, just want to make sure it's clear. If you're seeing different numbers that on your 458 and MMIS, the nursing facility should continue to work with a local AAA or APD case worker, case manager, to ensure that we have the correct information, whether that is you need a new updated liability sheet to match what's in MMIS, or MMIS needs to be updated to show the correct liability amount.
All right, we have another comment coming in. Again, the Oregon Hospice Association is happy to assist nursing facilities with payment delays and other issues that cannot be resolved in discussions with the hospice. All right, next question. What if the patient selects a hospice carrier that we don't have a contract with?
So in a nursing facility, you all, if you state you're going to carry hospice services, one of the services you're going to provide in the nursing facility, you have a responsibility to also let them know the individuals you are going to contract with. You do not have to contract with additional providers. So if they select a provider that you are not contracting with and you decide not to contract with, the individual either has a decision to make, and that's part of the care coordination of the conference, to either remain in the nursing facility and not receive hospice, remain in the nursing facility and receive hospice by one of the hospice organizations you contract with, or look at discharging to a nursing facility or another setting where that hospice provider is able to provide services. Again, you have responsibility to ensure and work with them around a safe discharge for those individuals. That would be part of the process. So again, you will have the right to decide and contract with whatever hospice organization you want to use or utilize in your area for those hospice services. An individual has the right to choose other hospice organizations. Doesn't mean that they have a right to have those hospice organizations come into your place of business to receive those.
All right, so another follow-up. Please know it is not that we are not providing updated info to the case manager on the 458. It is purely an MMIS problem that needs addressing. Case managers tell us, providers all the time, from every branch, that MMIS changes. This is the real issue that we as a provider and your case managers would like addressed. It is a system software issue with MMIS.
So I'm going to address that knowing that this is recorded and going to be on the web, which is a scary thing to say, but we will continue to work with our case managers around that. I used to actually travel and do training on MMIS related to state systems when it was first rolling out, and worked with actually several of you, some of our providers around some of our billing issues. The issues around the liability panel have been fixed as far as we are aware of. So if we're seeing continued issues with those numbers not correctly adjusting, we will look into that and make sure those are addressed as part of this. But So again, if you have information, this is part of the questions. If you have information, you're seeing that, please tell your case managers to contact central office. They have several contacts to talk about those so we can make sure we have any of those adjustments. If you feel like they're saying that and you're not seeing movement or there's questions on it, please let us know as well. You can contact, and I give my information, but Nathan Singer with APD, and I can make sure we get our correct individuals on it. You have your partners with Bull Roads, with the Office of Licensing and Regulatory Oversight, any individual from DHS, OHA that you're interfacing with, we'd like to make sure we have that information.
Okay, let's keep moving. Next question, comment says, poor Vivian, she's going to be swamped. The caseworkers are not able to do a lot of things with MMIS. Maybe they need more training.
And we appreciate these comments and information. So, you know, APD is always looking at opportunities to improve our services and make sure that we have workers that are knowledgeable and aware of how to utilize the systems and making sure that we're working to be a more efficient and effective office. So we appreciate the comments and we will look at it. Again, you know, it's our specifics. We want to be aware of those. Vivian's a great resource, as is all provider services, and I know she knows how to find us and come downstairs to us, and we work together quite often on cases. So again, if you go through DMAP provider services, you're seeing issues with that, and the same thing we'll be telling hospices. If they see issues and they're working through provider services, they have our contact information so we can help support and ensure the local offices understand their roles in the process.
All right, we have a comment. Lane County DHS workers are awesome. No complaints. Thank you. I'm actually from, no, I'm just kidding. I was going to say I'm actually from Lane County. Just kidding.